Welcome. This is a seminar on collaborative approaches to identifying and referring substance-exposed newborns. So we want to thank you for being here. My name is Amy Price. I'm with the National Abandoned Infants Assistance Resource Center, which is located at the School of Social Welfare here at UC Berkeley. I want to start by acknowledging our funders. We are funded by the Children's Bureau of the U.S. Department of Health and Human Services. The Children's Bureau has a long-standing commitment to addressing issues related to the intersection between child welfare and substance abuse. Since 1990, they have funded programs through the Abandoned Infants Assistance Program. That includes our resource center, as well as over 90 direct service programs since 1990. And these programs are set up to provide collaborative and comprehensive services to families who are affected by perinatal substance abuse and/or HIV with young children. The Children's Bureau also funds the National Center on Substance Abuse and Child Welfare, and we're very pleased to have with us Sid Gardner from the center. That center is jointly funded by the Children's Bureau and the Center for Substance Abuse Treatment, and it's set up to assist states, localities, and tribes in improving collaboration, policy, and practice to better serve families involved in substance abuse, child welfare, and the judicial systems. In 2007, the Children's Bureau also funded regional partnership grants in 53 agencies in 28 states and 6 tribes. And these programs are set up to improve permanency outcomes for children who are affected by methamphetamine or other substance abuse. And I want to just mention, there is a Take One table over there with materials from the Resource Center. There's also a copy of this hot-off-the-press document from the National Center on Substance Abuse and Child Welfare, Substance-Exposed Infants, States' Responses to the Problem. So in addition, the Children's Bureau funds 4 substance-exposed newborn grants, as we refer to them, and that's what you will learn more about today. So a little background. In 2003, Congress passed the Keeping Children and Families Safe Act, which reauthorized and amended the Child Abuse Prevention and Treatment Act. One of the amendments was to require states to create policies and procedures that address the needs of infants born and identified as being affected by illegal substance abuse or withdrawal symptoms resulting from prenatal drug exposure. So you'll notice in the final iteration of this bill, there was a clear omission of alcohol or prescription drugs. It very specifically stated illegal substances. And although CAPTA grants provide a relatively small amount of money to the states, in order to receive these funds, the states do have to provide various assurances. The 2 provisions are: states must require that healthcare providers involved in the delivery or care of a substance-exposed newborn notify the Child Protective Services system, and that a plan of safe care be developed for each identified substance-exposed newborn. So that leaves a lot to interpretation. It provides no guidance on the identification of substance-exposed newborns, provides no guidance on the plans of safe care in terms of who is responsible, what those plans should look like, and it very specifically uses the term notification as opposed to a referral or report. So it requires child welfare systems to figure out if and how they're going to respond to these notifications. So in response, the Children's Bureau funded these 4 demonstration projects in 2005, and the purpose of these grants was for them to develop models to implement these new CAPTA provisions, specifically to develop policies and procedures for identifying and referring substance-exposed newborns and developing plans of safe care for them, and also to implement and evaluate the impact of these policies and procedures, and to disseminate lessons learned. They're in the last year of their grant cycle, so this is part of disseminating what they've learned from these 4 years. Although, as you will learn today, these programs have different types of lead agencies. They vary in their models and their specific interventions. There are 2 common themes throughout or 2 common approaches among the 4 programs. One is that they all use collaborative work groups to develop and provide training on policies and procedures for identification and referral of substance-exposed newborns. They also have all hired and utilized specialized staff, specifically hired to engage families in the treatment programs and to help develop and implement plans of safe care. We are very pleased today to have a representative from each of the 4 programs with us who are going to share their experiences and lessons learned. To my immediate left is Celeste Smith from the Healthy Connections program in Toledo, Ohio. Next to her is Liz Twombly from the FEAT program in Eugene, Oregon. Enid Watson from a Helping Hand project in Boston, Massachusetts. And Christina Little from the C-SIMI Baby Steps program in Denver, Colorado. We're going to start with a brief overview of each project. We'll take a few minutes, each presenter will take a few minutes to give you a little bit of background information. Then we'll talk about collaborations, challenges and strategies, identification and referral issues, and then engagement and development of plans of safe care. We will take questions throughout, as I mentioned, so please write them down. Just make sure you write them so that we can read them. And after each section, we will stop and respond to any questions. Okay? So at this point, I would like to turn it over to Celeste Smith.
Good morning, everyone. Like Amy said, my name is Celeste Smith, and I am located in Toledo, Ohio. And our organization is actually located in a hospital, which recently the name has changed to Mercy St. Vincent Medical Center. Our target population is pregnant women that are substance using or SIN, which is substance exposed newborns. The majority of our referrals do come from within our own hospital, our OB/GYN clinic, our labor and delivery, as well as our pediatric system. St. Vincent's is located in an urban area of Toledo. And the key staff in that project is myself as the program coordinator. We have a clinical therapist that provides mental health services to our program participants, as well as does infant mental health with the moms and the babies after the babies are born. And we have a bachelor's level care coordinators, which provide case management for the program. Our main goal is to increase compliance with CAPTA requirements, and we do that by going out into our hospital system and providing education on the CAPTA requirements and what they are, as well as in some of the other community serving organizations. It was surprising to us that a lot of people in our community didn't even know what the CAPTA requirements were, and it was a law. So we do spend a lot of time educating the community on exactly what that means or what those requirements are. And we also want to improve access to and utilization of mental health services. A lot of these women have a lot of co-occurring disorders, so we're actually able to provide the mental health services right within our project. And for us, that has been very helpful, including the infant mental health services that we provide. With this project, we collaborate with maternal and child serving agencies, like I said, our OB/GYN clinic, our pediatric clinic. One of our biggest collaborations and helpful collaborations has been with our family drug court. They've been very, very, very beneficial as far as helping us to form relationships with our child protective services, which for us was very, very difficult. We also would like to promote consistent identification and protocols. And within our own system, we've identified different protocols as far as identification, with identifying mothers early and often in their prenatal care, as well as in our labor and delivery. Once these moms have been identified, what are the proper steps to go through to make sure that these moms and babies are getting the proper services that they need. We've worked with our child protective services. We had with identifying of marijuana. That was a huge issue because they were not really taking referrals as far as marijuana. I think our society on a whole has a really blasé of the way we think about marijuana. And so now we do have protocol, and our child protective services are really looking at these moms. Marijuana is a huge problem in our area, and what we're finding is that it's a gateway drug to other drugs. So they're not just smoking marijuana. They're drinking alcohol, they're smoking cigarettes, and they're using other drugs. We're also linking infants with services, like I said, the infant mental health services, also parenting classes we are also offered with our project. We also assist parents in completing service plans, which Once they're involved with Child Protective Services, they're given these intense service plans, and then they get into treatment, and they also have another service plan. And then they're with these other community agencies who also give them another service plan. So what we try to do is coordinate the care so that there's not a lot of duplication, because what we found is that there's a lot, everyone has all these different requirements, but a lot of the services are duplicated and everyone has their own agenda. And so we just kind of try to get everyone on the same plate so that they're doing the same thing, so that these women aren't going all over the place. So we don't want to have a lot of duplication of services. And like I said earlier, we provide a lot of trainings, not just to our Child Protective Services, but also we've done several trainings for our foster parents. We go into the nursing units within our hospital and provide training to the staff, to our physicians. We are a training hospital, so we do provide services to a lot of the residents as well as the attendings on substance-exposed newborns and the effects of substance-exposed newborns. And we provide a lot of wraparound services, the case management, the mental health services, and then getting them connected to other community, the other resources within our community.
Good morning. My name's Liz Twombly, and I'm one of the coordinators on the FEAT project, which is located in Eugene, Oregon. We're located in Eugene. We've worked very extensively with our county service providers, but we also have a statewide focus. So we work both at the county, try to understand issues that are happening within the county and how they can be brought out to the state as a whole. The lead agency is the Early Intervention Program at the University of Oregon, which is where I work. We're not a direct service provider. We are a personnel preparation program for early intervention providers, but we also work a lot with research grants and outreach grants. And we initially heard about this grant because we were working at the state level to help implement one of the other CAPTA provisions related to the referral of children 0 to 3 who were involved in child welfare into early intervention. So the state was really trying to figure out how to make that happen. And so we had started working with them around that. And when we heard about this particular grant under CAPTA, we thought perhaps we could help facilitate that process as well. And certainly one of the advantages we have had being in a neutral agency that doesn't provide direct services is that we can help facilitate some of these different partners, but we don't really have a vested interest in who's getting funding or whatnot. So we're really seen as a neutral player. Our target population, similar to Ohio, is pregnant women who are using substances, as well as babies who are identified in the hospital and their care, sort of within the first year to 2 years. And the key staff really has been the coordinators in terms of replicating or doing something like this, and in coordinating. I'd really say that one of our primary roles is facilitating the work group meetings and bringing together some of the state level folks. So really just facilitating that process between all the different players has been an important piece in moving the project forward. We also did write in a person to provide direct services, so that's our family advocate. It was one funded position, and we've learned a lot through that particular staff person. Our goals and objectives have actually been to provide recovery support for pregnant women and new moms. Clearly, that's one of the primary things that this project is looking at, is getting women into treatment as soon as possible and really supporting their recovery. We've also done a lot of assisting in developing protocols or helping facilitate, again, that work group for systems to sit down and go, okay, how is this working in the prenatal clinics? How is this working in the hospital? How does child welfare respond? And what are ways to make the whole process work smoother between all of these different collaborators? So we've done a lot of work with protocols for prenatal clinics, protocols for screening, prenatally screening when women are in labor and delivery in the hospital, looking at improving discharge planning for substance-exposed newborns, so how to get information to postnatal providers, either care providers, foster parents, or pediatricians or the medical and health community who's going to be providing care for these children. And then looking at improving systems of communication between prenatal, hospital, postnatal providers is a huge issue, and so how to really look at improving those systems and continuing to develop and support just the network of collaborators, so to really keep that moving forward. Some of the strategies that were kind of specific strategies, I guess, were the family advocate, so that position. In our community, public health works with pregnant women. Healthy Start has started to work with pregnant women, first-time moms, doing home visiting. But they're very limited and they're not very flexible services. So the family advocate is really a person who has a lot of knowledge about recovery, treatment resources, has the ability to work very flexibly and in different, locations with women. So that's certainly been an important strategy. The interagency work groups, like I said, we have county work groups as well as a state work group, training for folks prenatally, training in the hospital, training in child welfare, training in parent support, and then also what we'll talk about a little bit later, which we call the substance-exposed newborn team, which is a hospital-based team that helps make decisions about safe care plans for children. So those are our main strategies that have been employed throughout our project.
A Helping Hand is based in Boston, and we are housed in the Department of Public Health, Maternal and Child Health Division. And we work very closely with our Child Protective Services Agency, who will refer infants who are 90 days old or younger with prenatal exposure to illegal substances. We have been following the rule of CAPTA carefully, and much to our regret are not including children who were prenatally exposed to alcohol. But we do address prescription drugs. In Massachusetts, we find that most of our mothers are using opiates and prescription drugs. It's some marijuana, but it's the opiates that are of concern to us particularly. We have the project director, which is myself. I work for the Institute for Health and Recovery, and the Department of Public Health has contracted with us to do this grant that we helped write. And our key staff, other than myself, and I'm not nearly as key as our workers, our peer workers who work directly with the mothers. The staff, I'll talk to you briefly about them later, but they are also mothers in recovery and, who are working with the mothers of substance-exposed newborns. We have 3 sites across the state, one in Cambridge, and then Springfield and Worcester, 2 large cities but much smaller than Greater Boston. We all want to increase compliance with the CAPTA requirements through collaboration, and we've been very fortunate to work with a very enthusiastic Child Protective Services leadership in Massachusetts, and we have benefited from technical assistance from Sid Gardner and Nancy Young. They have come to Massachusetts, and their work with our child welfare system has helped pave the way for our Helping Hand collaborations. And as my colleagues, we're all trying to increase service utilization to the substance-exposed newborns and their families. And like Liz's program, we have really wanted to make sure that early intervention referrals are made. Something that we've learned is that most of the infants with whom we worked have not had developmental delays in their first 6 months, so we're often sending them back to early intervention for a reassessment later on in their young lives. We have one statewide steering committee that is comprised of child welfare. And then we have 3 local collaborative teams or implementation task forces. As you know, when you have a statewide steering committee, you have the statewide leadership, but in the local collaborative teams, we have members of each child welfare agency and early intervention, all of those people who are actually doing the work. And as you imagine, sometimes there is a slight disconnect between the frontline staff and the leadership that we can address throughout our different team meetings. Crucial to our model is the work of the family support specialist who, as I mentioned, are mothers in recovery, and they bring unique and wonderful skills and experiences to working with the mothers of substance-exposed newborns. We have found this model to be really helpful, even though there has been a learning curve for not only these women, but for the Child Protective Services workers and the other staff who are not used to working with a mother in recovery. And there's been the need to do some interpretation and some validation of these women. It's not every person that is an identified person in recovery in her job title. And so we have taken great care to make sure that these mothers receive the support services they need to maintain their own recovery and to have good clinical supervision.
Christina.
Okay, so I'm Christina with the C-SIMI Baby Steps, and C-SIMI stands for Colorado Systems Integration Model for Infants. So in order to be much friendlier and easier to talk about, we kind of call ourselves Baby Steps. And our lead agency is the Denver Department of Human Services. In Colorado, child welfare is what they call, and many of you are child welfare workers, so you'll understand the state administered but county supervised, or vice versa. So essentially each county has different policies and different ways often of doing things. So Denver is the largest county in Colorado and a very largely urban county. And skipping down for a second to key staff, we kind of had an advantage right off the bat because our principal investigator is Dr. Catherine Wells, who has joint appointments both at the Denver Department of Human Services as their child abuse neglect doctor, but also at our largest birthing hospital and our largest safety net hospital, which is Denver Health. And so kind of from the bat, we were kind of lucky that we had, well, along with Baby Steps, we had our feet in both kind of worlds, and then also with a partnership where I'm from, which is the University of Colorado Medical School. So I'm kind of reflecting as you guys talk that we were lucky off the bat to have a little bit of kind of integration already. And what we decided to do, and we'll go further into this later when we talk about collaboration, is that we are running a services team. When you see target population, we're providing specialized casework services through DDHS to, as it says up there, substance-using women who are pregnant or have newborns 72 hours or younger and are reported to the child abuse hotline. So we're not essentially a referral based services. We are picking up kids that are being reported and families who are being reported into our child abuse neglect hotline in Denver. And one of the things is the lead agency is Denver Department of Human Services, but that's not why we decided to base our services team out of Human Services. We actually ended up doing that because that's what the community wanted. As I said, we'll get into collaboration a little bit later, but people from other organizations felt like it was really important to be able to provide a specialized response out of Child Protective Services. We also wanted to try to capture as many people as possible, which is why we left things fairly loose in terms of going a bit beyond the strict interpretation of CAPTA to look at other, of alcohol, look at pregnant women. What we didn't realize is that there were about 30 reports to the child abuse hotline on pregnant women using substances anyway. So, and there was a very limited response that CPS was able to give to them. So our model was really built on what the community asked us to do. So in general, we were really all about, or trying to be about systems integration and making the best use of of what's already available in the community while building in, hopefully, some specialized services as well. So our overall goal was to really try to pull, as everyone else is talking about, the hospital system, the adult treatment, substance abuse treatment system, judicial, everybody to talk about, okay, what's best practices within your world and how can we do a better job of integrating some of the great stuff we already have going on. One of our, again, major objectives, as with everyone else, and we'll talk about it more with collaboration, is that when we first received this grant, we cast the widest net that we could possible and said, anybody from anywhere, whether you're foster parent or providers in other ways, birth parents who have been through the system, let's all get together and talk about what we have going on. And trying to sustain that has been a challenge, an opportunity, but also a challenge over the years. One of the major things we wanted to do from both the hospital and the child welfare perspective was to increase our identification. We were talking about this before. In both systems, it's not great setup to just say, oh, okay, well, we have 90 substance-exposed newborns coming in the child welfare system this month. We have an administrative state system that the child welfare system has to use that doesn't have a neat little checkbox that says substance-exposed newborn. So one of the things, and actually same for the hospitals too, it's not as easy as one would think to go, okay, how many substance-exposed newborns were there coming into this huge county in Colorado, this month? It's not really set up to do that. So that's some of the work that we're doing. In terms of direct services, we wanted to provide an enhanced and specialized child welfare response. So what we've done is we've been able to fund a little tiny bit of a couple of frontline child welfare workers to not handle every single substance-exposed newborn case, because that would drive them rapidly insane, although through some miscommunication that happened for about a month. But to train people in even more than they already get training in terms of substance abuse, in terms of newborn issues, in terms of the parent-infant relationship and postpartum depression. So to provide specialized training, but also to provide enhanced supervision is one thing that we've really wanted to try to do. So we have a multidisciplinary team, a physician, I'm a parent-infant psychologist, a child welfare administrator, and provide increased supervision to the two workers that we were able to have in this program, and do staffings every other week so that we could talk about all kinds of different issues. And then to be more assertive and to link families into community services much more quickly, again, by partially creating a casework team that was much more sophisticated in terms of, okay, where are the beds today in terms of maybe a residential for a pregnant woman or a new mother. And so to try to fast track into some of those systems we already had going.
So one question is, how much have your projects been able to use your grant and to leverage the much larger state and legal money already going to SIN expenses and costs?
That's one of the goals of our final year, is to start facilitating that kind of leverage.
It's just been an interesting time to run this grant. So we started, and financially states were doing okay, and in the last year or two we've had this huge crash. I think one way that this grant has helped in that we've kept the conversation and we've kept the focus, and people have continued to kind of have this spotlight on the substance-exposed newborns, so we didn't lose as much money as was potentially forecasted when they first put out some of the state budgets. So we're trying to maintain services at this point and then hopefully build as some of our state funding becomes a little bit more secure.
And I'll say, one thing, again, we weren't able to use a lot of the direct money to pay for services, but what happened in our community is exactly what you're saying. Because we tried to pull in so many people and we were fairly relentless and motivated and excited about this and passionate about this issue, is that when we started pulling in other people, you start to find other people in maybe other systems that are very passionate, or like, oh, wow, we were able to engage the judicial system in Denver, both the Department of Probation and the Juvenile Court, and have been able to leverage really what started out with this grant into probably 2 or 3 more grants coming in from different agencies, from various federal sources. And really that was about kind of literally somebody saying, oh, I'm working with substance abusing moms or women. never occurred to me they have babies. I mean, honestly, and getting very passionate about that idea. So I think creating that sense of passion is one of the best ways to leverage.
Enid, there's a question for you on how do you monitor the family support specialists?
That's a very good question because that's a very important task. I provide clinical supervision to the Cambridge, to all three of the family support worker specialists. Each of the three regions has their own supervisor of the FSS, but I provide supervision over all three and the one that's based in Cambridge. And we have made sure that these women receive adequate training. We have a whole list of training topics that we make sure that they attend, and we work very closely with them to make sure that their communication between child welfare is really good. That's been important. So supervision is critical.
Mm-hmm. And related to that, Liz, what are the qualifications for a family advocate in your program?
You know, we look at folks who can provide the support emotionally, who have flexibility within their schedules to be able to respond to folks later in the evening, on the weekends. We want folks who have a good knowledge of the treatment community, and we have had several of them have also had their own history with addiction and are in recovery themselves. That certainly has been helpful, but it wasn't a requirement of our family advocates. They had to know treatment and understand recovery and have some training in that, but that wasn't absolutely a requirement.
Okay. And Celeste, related, do you train parents on caring for the special needs of SIN in their care? What training do you use?
The trainings that we've provided have been mostly for our foster parents, and what we've been doing is the foster parents were bringing these newborn SIN-exposed babies into our pediatric system, and they were having these babies that were crying all the time or failure to thrive, and didn't have a lot of history from our child protective services as to what was wrong with these babies. So our pediatricians were identifying that these were a lot of our substance-exposed newborns. So what we do with a lot of the foster parents is provide things like swaddling and educating them on what a substance-exposed newborn is, and we educate them on all the illegal drugs that are out there and the effects of these drugs on these newborns during pregnancy. So the majority of our education is going to our foster parents. If these babies then we find are being returned to mom, we try to educate mom on what to look for, some of the delays that might occur, some of the things that may be because of their drug use, not to point blame, but just to give them education on how to deal with a lot of these issues, the crying, the high-pitched crying, the crying all the time, and how to comfort some of these babies because sometimes there's really not a lot you can do to comfort them.
And one more question for you, Celeste. Just how big is Mercy St. Vincent's in terms of deliveries per year, and how big is the CAPTA grant?
There are two main hospitals in Toledo, and probably St. Vincent's is probably the second largest as far as births. I would probably say, and this is just a guesstimation, about 700 or so births a year from Mercy St. Vincent's Hospital. And I'm sorry, what was the second part of that question?
The size of the grant? I assume it was the SEN grant that you received for this project.
$250,000 a year for 5 years, and we are all going into our 5th year.
So, Celeste, since you already have the mic, if you can move on with collaboration issues.
Okay, our existing collaborations right now are with our pediatric clinic. So we're getting a lot of referrals from the pediatricians who are actually seeing a lot of these babies that are coming in through the clinic, either through the maternal mother or through the foster care system, or the foster parents are bringing these babies into our pediatricians. We're also they're identified in the OBGYN clinic through our OB doctors and residents. And I'll talk a little bit more how these women are identified. We have wonderful nurses at Mercy St. Vincent's who are really the ones who are identifying a lot of these issues even before the doctors are seeing these moms. These substance-using women are talking to the nurses. So these nurses are really the ones who are identifying the issues even before the doctors reach the moms. Our early intervention and Help Me Grow is also another one of our collaborators. And I'm sure a lot of you know through funding issues, they're becoming less and less because of funding issues, having less contact with a lot of these moms. In our state, just recently, the moms have to be first-time moms to even to get any of the services. And it wasn't like that when the grant first started. This just recently, and they're still going through, I guess, issues as far as how to deal with these funding issues. We're working with our substance treatment. We actually one of our collaborators is one of our main treatment inpatient that provides inpatient services within our county, is also one of our partners in this grant as well. And we also provide the parenting services that we provide. We have parenting classes that are interactive parenting classes right on site within our agency that provides parenting classes with the mom, and it's interactive, so they have the babies with them. Even if mom does not have custody of the baby, working with our Child Protective Services, there's transportation, so the babies are also brought to the parenting classes. So they're interactive parenting classes. Our care manager is a very important part of this project as far as helping the moms navigate through the systems of care and forming relationships with these moms. Our biggest challenge at the beginning was with our Child Protective Services, which we have a wonderful Child Protective Services, and we've gotten their support with this project. The director has been very supportive, but what we found was that it was very difficult for his support to trickle down to the powers that be, the actual people that are out in the field providing these services. And so it was very difficult once these moms were identified as substance-exposed newborns or substance-using moms during pregnancy and referred to our Child Protective Services, that they have their own protocol and procedures that they need to follow. And these moms were given case plans and were inundated with a lot of services, so they really didn't have a lot of time to participate in our program. And so what we did is we ended up forming a relationship with our family drug court. It started with one client, and we formed this relationship with the magistrate, and she thought our program was wonderful, and that the services we provided were wonderful, and that Child Protective Services needed to be working with us, that we all needed to be friends, and we all needed to get along, because we all wanted to provide the best services for these women, and we all wanted to have good outcomes, and we couldn't do that if we were, doing it individually, that we needed to work together. So that relationship with our family support court and drug court was very, very beneficial for us as far as providing the services, as well as getting out in the community, providing the training and letting the other organizations know exactly what we were doing.
So in Project FEET, as I mentioned before, we have our Lane County, which is our local work group, and then a state work group. And both of those work groups have representatives from these different organizations. We have prenatal, perinatal, postnatal medical providers, the birth hospitals, social workers, nurse care managers, all the different folks who interface with women and babies. Child welfare, obviously, treatment providers, mental health organizations, parent support agencies, family members, both foster parents as well as birth parents have been involved at different levels, and then early intervention. We had a similar issue. We've had early intervention at the table a lot, and because we interface at the university with our local early intervention provider, we talk and communicate with them frequently, but these very little babies aren't showing significant enough delays to be eligible in our state for early intervention. In California, something like First 5 may be able to pick them up as at risk, but in Oregon, we have pretty stringent criteria. So we do what I think Enid was saying was rather than just refer these children once and have them screened once, it's like really reminding folks to go back every 6 months and take a look at these children again. So within our collaborations, another player who's not listed here were the medical labs, and they came into play in that many of the different labs in the state have different thresholds that they were actually testing children under. So if you sent your sample to one lab, it may come out positive. You've sent them to another, it may not. So at least within our county, we were trying to get very coordinated with what was going on in the labs. We mapped, when we first came together, we mapped out what was available and looked at resources and then also developed goals. And then we split our group. We had a large working group, but then also had sub-working groups. And they really fell out in terms of who dealt with the prenatal pregnant women in our community, what happened once they went to the hospital, and what was going on within the hospital. There was another sub-work group, and then postnatally, once those babies were discharged, who was providing care for them. So the work groups really worked independently, the small ones, and then we would come back together again and try to, make sure the flow between those different time periods was really being addressed. Some of the collaboration challenges, as you can imagine, are information sharing. And one of the solutions to that we found was really if women engaged with a family advocate while they were pregnant, it was much easier to share information between the different systems. So the family advocate could help with that information sharing between the 3 different time periods. So that was very, very helpful. Another solution was at the hospital, we had what we called the SEN team, the Substance Exposed Newborn Team. And this isn't necessarily just for women who got red flag through child welfare, so child welfare was going to be involved. It could be anyone who along the way had identified at some point, but most of them have child welfare involvement. So when child welfare was coming to the table, we really tried to expand who was involved in that discussion about safe care planning. And so that really helped with information sharing. We had in addition to to the caseworker who was looking at it, an addiction specialist who came from child welfare, who really understands the treatment community. We also had a treatment provider, and this was one of those funding issues. While we were talking about this, child welfare had a little extra money potentially, which they helped to use to have a screener come in from the treatment program who could come to the hospital and determine if this family was really a good match for residential treatment or outpatient treatment. So we had treatment providers there, and the family advocate would be there. The family was involved in really deciding what was going to be the next steps. But having a broadened team to help make that decision helped with that information sharing and with also broadening the potential solutions and outcomes for the family. Another challenge was engaging OBs in the prenatal community. I think because the crisis comes in the hospital usually, that's why, we could get all the medical providers in. The crisis wasn't necessarily as apparent in the prenatal visits unless somebody was bringing it up, and they didn't really want to deal with the crisis necessarily in the prenatal community. So one of the solutions to that has been really in our community collaborating with other initiatives, Lane County Public Health, Lane County Prevention, and we have the dubious distinction in Lane County of having one of the highest fetal infant mortality rates in this state, and our state is also very high in terms of other states. So Lane County Prevention started an initiative at a similar time related to these fetal deaths, and so they're very interested in what's going on prenatally. So we have more energy right now behind really trying to outreach to the prenatal community, do more trainings there, develop more, get champions on board, and really, really push the envelope in that particular community. So that's been very helpful for us. It's not just us trying to push it, but a much larger group. So.
And just a reminder, if you could address issues of confidentiality as we move forward.
All right.
I'll start with confidentiality. We have, because I had forgotten, we have put all of our protocols through Brandeis University IRB, and we have the mothers sign consent forms in order for the different agencies to talk with each other, and so we're very cautious of that. I don't know anyone's names as project director, so we feel good about our confidentiality. I want to say, as far as our collaboration, in Massachusetts, the Department of Public Health and the Department of Family and Children and Families, we just changed our name, have a long history of working collaboratively together, and that has really benefited us. And we really work with our child welfare agency very closely. And we're a guest in their home, and they have been quite hospitable to us, and so we're very thankful to that, to them for that. The rest of the people that are listed here are crucial members of our team. We have these different teams, as I mentioned earlier, and we have not been as successful engaging birth hospitals as some of my neighbors here on the panel, but we have done really well working with child welfare. And we also do provide priority treatment in Massachusetts for pregnant and postpartum women in residential treatment, and so that has been a big help. Another very important partner that isn't listed on here as such is our State Department of Public Health Bureau of Substance Abuse Services. And so we have done a lot of linkage development and resources for treatment. And we are, there are a variety of forms of collaboration. We fall firmly under the coordination branch. We do not have we do not sit in child welfare. We do not have staff who sit in substance use disorder treatment, but we coordinate our work together, and that has worked out well. I think a fuller collaboration would be welcome down the road, but right now we're very appreciative for this opportunity. As I mentioned, we have had more difficulty engaging medical staff. One of the main reasons is geographic. In the two cities outside of Boston, in the western and central parts of the state, there are only one or two birth hospitals for each Child Protective Services office, and that has worked out really well. In Greater Boston, as you might imagine, we have at least 17 hospitals that have labor and delivery services, and we just have not had the time or personnel to engage so readily with all of those birth hospitals, though our child welfare folks have worked with us very closely to do outreach, and we have had some great trainings that we have done for hospitals and in hospitals. One of the other solutions that we've had is we have been the recipient of a number of those grants to which Amy referred to earlier. And so in Springfield, we have 3 overlapping grants. And so one of those projects did a lot of work with the birth hospital. So we have staff from that birth hospital, from 2 birth hospitals, who are very closely connected to that implementation task force, and that has been wonderful. The overlapping grants has been a bonus in that regard, though I think sometimes our child welfare people are feeling that 3 overlapping grants isn't what they would have chosen, but we're working with them nonetheless.
Christina?
So, like everybody else did, and like I talked about earlier, we did very early on these interagency planning groups, and originally we were going to be like, okay, well, let's have somebody, and what we wanted to do is understand each system's protocols for addressing families with substance abuse in infants, and then to look at what their protocols are, what could be done better, and so we were going to do, well, here's a treatment group and here's a child welfare group, and somebody said, well, that's stupid because that's not systems integration. You're perpetuating silos if you're not going to have child welfare people on your treatment group and so forth. And so we really split up into groups to look at identification, assessment of families, treatment of families, and also public policy and legal issues, which is where some of the confidentiality issues come in. And then what we did is, we found a lot of people will participate. It's a new project, and Dr. Wells said, I'd like you to come to this meeting. And then you really find people that are really committed and passionate, even though nobody has any time, and it's another meeting, you have to make it more than that. And there are people that would get, just committed to the cause. And so one of our big, it's everybody's challenge is to develop a sense of understanding and trust. And like I think Celeste said, if you can have all your administrators from a system buy into something in theory or develop an MOU, but if you don't have frontline staff or middle management staff, it's not going to come down in the way you want it to. And so one of the things that we really were interested in is having both frontline staff with the buy-in of administrators come in and say, okay, this is what it's really like. You might have this protocol that says X, Y, and Z are going to happen, but nobody ever does it because we don't have time, and frankly, we don't like so-and-so over at that hospital. And so that was really a great thing. One of the things that I never thought we would have to do, but once we started trying to do it, we found out how impossible it was, which was we went through the CAPTA legislation and pulled out certain terms that, like Amy said, are a little loose and maybe open to interpretation, like plan of safe care. And we gave each of our working groups the challenge to come up with a definition for even newborn. You wouldn't believe how much fighting is too strong of a word, but discussion we had about what's a newborn and what's not a newborn. And in the end, we had to agree to maybe disagree about some things, like plan of safe care and what's substance exposed, what's affected by, what does it mean to have a notification to child welfare. We don't even have the possibility of such a thing in our state right now. And one of the things we realize is that when you have different terms for what seems like a really basic thing, like I'm a psychologist, so assessment kind of means one thing to me, and to child welfare it meant something very different. What I would have called an investigation, they call a family assessment. What I would have called a report to the Child Abuse and Neglect Hotline, they would call a referral. And I found that I personally was getting myself into trouble by using words that meant really different things to people. And so that was something that I really had not a thought of doing that was incredibly important. We did the collaborative values inventory, which Dr. Gardner has developed. And one of the things that we did was we decided to perturb the work groups a little bit, which meaning everybody gets together and in public, you pretty much have a good discussion and we're nice to each other. And then we decided, well, we're hearing. After one meeting, I went to the ladies' room, and there were a couple people in there going, "Can you believe how badly they were picking on us?" And this was from child welfare, and then from the hospital, they were saying in another bathroom, "Can you believe how bad they were picking on us?" And so we tried to do something to really bring some of those feelings out. And at the beginning of the project, our child welfare system and our juvenile court system were having pretty public, very heated, knockdown, drag-out conversations going on. And so it was really helpful to get people to kind of be real and do it in a safe way. And that's why identifying a lead facilitator was helpful. Not only did we have somebody that could kind of keep track of the meetings, who's coming to the meetings, what are you doing in the meetings, but at times we brought in someone who was kind of more neutral. So we brought in actually she's not a police officer, she's more than that, but who's really been instrumental around the drug endangered children area. And she came in and she was relatively neutral to at least the Denver community. And that was helpful because she cared, but she didn't care about anybody's specific issues. And so that was a really helpful thing because she was able to kind of really kind of mediate things and bring everybody together. And I think once everybody kind of developed that, a true relationship, and then started working some cases together. So it's like, oh, hey, remember that mom from when she gave birth in the hospital and then she went out to have a cigarette and never came back, and how we worked together on that case. And being able to have those real relationships and to maintain them over time, even when you have staff turnover, And we've had that both at the hospital and at child welfare. And having somebody that can kind of maintain, that nugget of relationship. And so all of those wonderful things that we're saying there, and also in terms of confidentiality, I think there's several things you can do to work with issues of confidentiality. And I would say one of them is making those real relationships where you kind of start to trust each other, because whether it's you or one of my clinicians that have worked a difficult case together and had a good time doing it, but also a good outcome for the family, that's when I think you can start address those issues of confidentiality. Typically for us, if we don't often have parents decline to sign releases of information, especially when there's kind of a treatment team focus. They might be an open case with child welfare. They might be under assessment or investigation for child welfare. But usually parents, in my experience, often like people to have shared information. And it might be because I mainly work with child welfare involved families, so that's kind of already there. The other thing that our project actually led to was a memo of understanding between the Part C system and child welfare, which had been very frustrating for the developmental disability system, because child welfare was really leery of sharing some information about the child, which would kind of lead to information about the family, and they were very worried about confidentiality. But I think as a part of this process, we were able to sit people down and say, okay, this is why your developmental disabilities or early intervention system needs to have this information. This is why child welfare is worried about you having the information. And so I think having memos of understanding between systems is another way to address that.
Great, thank you. For Celeste, what feedback have you received from doctors and medical residents regarding training? Do the medical residents in particular feel that they need more training on SEN issues?
That's a wonderful question. We have gotten some excellent feedback, especially from our attendings, as well as the residents. One of the things that we've been told is through medical school that a lot of attention is not paid on as far as the effects of substance use during pregnancy. A lot of the doctors, as well as the attendings and the residents, are not very educated on the effects of the illegal drugs during pregnancy, and have been very, very, very accepting of the education. We get these residents that come through in different rotations, and so the attending is like right there. We got a new group coming in. We got a new group coming in. When can you do this training? So the hospital has been very receptive, and so have the residents. And through this training, then the residents now know that we have this project within our own hospital, and they themselves are letting the nurses know, please refer this mom to that program. We have this program here. Could you make a call or make a referral so that this mom knows about the project? So it's been very beneficial for us.
I think this next question will bring either a smile or a frown to your faces. How have you assured the sustainability of your projects?
That's what year 5 is for. We're working hard on that in Massachusetts, and we've looked at a number of different opportunities and strategies, but that is the work that we are about to do.
Yeah, assured is kind of a strong word. There's aspects of the project, the FEAT model, that can be replicated without a lot of funding, just really a will and a desire to replicate, because it is really about just shifting the way services are provided and sharing resources a bit more. But the family advocate position, at this point, what we're looking at is, grants that will help sustain that, and educating more people within the state about the importance of having those kinds of services available in different counties, and then continuing to work with the state, again, as they free up some of their funds to include these in some of their budgets.
And related to that, someone pointed out that measurable outcomes are often key to funding, and so I was wondering how you measure the outcome of your programs or interventions.
We talk about this amongst ourselves a lot, actually.
I think, the thing that's hard to measure, I think, is a lot of the work that's done around the collaboration and the infrastructure shifting. One of the things that we're doing is we are able to use the child welfare database, and we've created a standalone database to track progress of all the substance-exposed newborns that are seen by the specialized case team, and then the many, many more that we don't have capacity for, and try to look in some sense of whether it's not a true study, so we can't say, that our team did this so much better than what a typical family is doing in terms of outcomes. But at least we're able to do some very nice descriptive work. But I think it's very challenging. Really, to me, on our project, a lot of the true work has been on the relationships, on the shift in the community in terms of awareness, and that's, for me, a hard thing to measure and kind of even quantify.
And for us, it's been the same thing. We have a wonderful evaluator with our project, but so much of this time has been spent forming these relationships, especially with our child welfare agency. So a lot of that is very difficult to measure. That forming relationship is very difficult, but has been, I think it's essential in having a positive program. We're also working with a lot of different other programs within our community to look at some of the services like the care coordination, to make those services billable within our state, so that for sustainability, because a lot of our services are done by our care coordinator. So if care coordination was a billable service, it would be very beneficial as far as sustainability in working with these families.
So real briefly, just wondering if any of you has a sense if the number of SEN referrals has increased as a result of or since the inceptions of your projects.
For us in Toledo, I think that, yes, it has increased because people now, I think these moms were always in our hospital. They were always in our system and even in our private, working with the private doctors. But no one wanted to really deal with it because once it was identified, then what should I do? What do I do if there were no programs or anyone working with these moms? So I think, yes, it has increased. Is it the best that it could be? Absolutely not. Can we do better? Yes, we can. But at least now people are starting to identify, and because there is a project within our system or our hospital that these women can be referred to for services. And we're actually working with these moms. We want to get them as early in the pregnancy as possible. And when we initially wrote this grant, we were thinking we would get them after the babies were born. And so we had to readjust and regroup and relook at what we were doing because we needed to work with these moms during the pregnancy and to identify them as early as possible.
I just want to move us along because I have a whole pile of questions here that refer to identification and referral issues. So there seems to be a great interest in here. So I want to move us along to get to that. Liz.
While we're talking about identification and referral, we'll use two different terms. One is testing versus screening. And in testing, we're looking more at toxicology testing, things that would be sent to labs, versus verbal screening of women at different points in time. As you may know, there's a lack of consistent testing policies as well as inconsistent verbal screening policies, both prenatally and at the hospital. So several of the projects have worked at looking at the consistency of how those are occurring and what is best practice in terms of verbal screening, in terms of what we know from the field. The inclusion of alcohol or legal drugs, in our community, people did not want to keep it focused on illegal drugs. And if you were working more postnatally and specifically with a child welfare group, then, in Massachusetts, it made sense to stick with the illegal substances because that's why they were involved with child welfare. But no one wanted to exclude in our community, if we were looking at the prenatal community, what was going on with smoking and alcohol and prescription drugs. Who's responsible for screening and testing? People have come across different ways. It seems to fall on the nurses many times, both in prenatal as well as the hospital community, since they have more interaction with the patients. And then the communication between OBs and pediatricians. Just quickly in terms of confidentiality, what basically in our community there was concerns around communication and HIPAA requirements, and basically, they were saying as long as it's related to the care of the infant, that HIPAA doesn't play in. The mother's risks and social risks come into play if they impact the medical care of the baby. So in the FEET project, we really created several different protocols for identifying women and screening. In your handouts, there's a couple. One is related to more the prenatal community. It says first visit on it. So it really kind of shows how a nurse may go through and do prenatal screening as well as a brief intervention during that first visit. And then subsequent visits, follow-up visits, were also very important. So on the flip side, it talks about what the algorithm would be like for following up with women. In the first visit, they might think about it, but if you continue asking those same questions by the second or third visit, a woman may actually be ready to take a referral or consider cutting down their use, so that coming back to it at each time point is very important, because it's a process for them to move to accepting treatment. So we created screening algorithms. We also created materials, educational materials to use in prenatal clinics. And then in the hospital settings, there was several protocols created as well. And we have an algorithm that is also in your handout related to what happens after an interview. When they come into labor and delivery, there would be an interview, observation of what was going on with the family during labor and delivery, as well as a review of prenatal records. If any of those indicated certain risks for substance-exposed newborns, they are kind of pushed into this algorithm that also outlines what kind of testing would occur for the baby or for the mother, and what kind of action should be taken. And these have been implemented fairly consistently in one of our larger hospitals. So, and again, because they were doing different things and treating each case in a different manner, that's been nice in terms of creating some systems that are real consistent.
Okay, as far as some of the Healthy Connections protocols, what our women are identified, first of all, we have wonderful nurses in our OBGYN clinic. I mean, fabulous nurses that are working with these women. And at the very beginning, there's a verbal history at all prenatal visits. And a lot of times these women are very open and honest with these nurses as far as identifying their substance use. Whether it is illegal substances or legal substances, including alcohol. With that, there's also a consent for urine toxicology, and probably 80% or 90% of our women actually sign this consent. The other 10 or 20%, we actually assume or use as positive. If they don't give consent, we just automatically assume that those are positive, and that's how we count those as positive. But we really don't have a problem with the women signing the consents for the urine test. And once those tests come back, whether it's a toxicology report or a verbal, those women are all referred to the project. We do ask our nursing staff not to really explain our project to our moms, because we feel that we do a better job as far as explaining, and then it gives us an opportunity to start to form that relationship with that mom. Those women are then referred to our case manager, and then if treatment is after an assessment, then they are also referred to treatment. Since we have started this project within the last several weeks, we are now accredited, our hospital, and we are actually doing treatment. We have a certification now, and so we're actually providing intensive outpatient treatment right within our facility, and we are extremely, extremely excited about that. Our labor and delivery protocols, a toxicology test, and I don't want to get on my soapbox about this and I know a lot of my colleagues will not agree with me on this issue, but I feel that every woman that comes into the hospital should be tested. And I was at a training with Ira Chasnoff, and he talked about FAS and FASD, and he used the term NEMO, N-E-M-O, not in my office. And I feel like a lot of our birthing hospitals are using that within our hospital systems. it doesn't happen. It's not in my office. These women aren't coming here. And oftentimes these women are identified or tested because of the way they look, or if they come in and they have a history of drug or substance use, or if there's no prenatal care. But I think a lot of it, there's a lot of profiling going on, and I hope not in your hospitals or not in your state, but I know it's happening in ours. So I'll get off my soapbox there. But they're identified through a toxicology test that's ordered by the doctor at the hospital. And like I said, it's often because of history or no prenatal use or no prenatal history, or they just have that look and they'll test. Then those moms are then referred to our hospital social worker, and our hospital social worker, if they're positive, go in and they talk to mom and then let mom know that they have to make the call to our Child Protective Services. And then after that is done, then the social worker then calls our coordinator or calls our department, so that then we can go in and speak to these moms about our project. But the social worker is the first person who actually has contact with these moms. And it used to be that all newborns were screened by our early intervention specialists, but because of funding issues, this just changed. And the only ones that they're actually going in and seeing are the moms that are delivering for the first time, or that are first-time moms. And that just recently changed because of funding. Also, there was a question, is marijuana seen as an illicit drug in our state? Well, marijuana is an illegal drug, regardless of how people feel about it personally. It is an illegal drug, and those moms are referred to our program. And the second part of that question is, when it happens, if only mom is positive for drugs and baby is not, at delivery, there is a referral still made to our Child Protective Services, and then it's up to the Child Protective Services what happens after that. So oftentimes it depends on the previous history or what is actually going on with the mom at that time. But marijuana is an illegal drug, and we do look at it as an illegal drug regardless of personal feelings about marijuana. And I can't forget to talk about confidentiality. Our project is IRB approved through our hospital. There is an informed consent that each of the moms do sign to participate in the project. We are also now a collaborator with our Family Drug Court, and we are also on their consent, so that we're now all able to share information amongst ourselves.
Well, while my colleagues have been talking about their prenatal work, I don't want you to think that Massachusetts is heartless around prenatal work. So I will just briefly say that we are very active in our SBIRT protocols, screening, brief intervention, referral for treatment, and I have been training about 35 health centers in the past couple of years on SBIRT protocols for women of childbearing age and adolescent males and females to prevent substance-exposed newborns. I also wear another hat. We all wear many hats nowadays. I am the state fetal alcohol spectrum disorders coordinator. So in all of the work that I do and the Helping Hand does, we lift up FASD, and we're just in the process. We're going to have a whole FASD awareness week. I know there's an FASD awareness day coming up here in California. So we are doing that work. As far as the little SENs here, our little substance-exposed newborns, in Helping Hand, the birth hospitals will identify the children, and that is not consistent across the hospitals, and that's something that we're hoping to really tighten up in year 5. Once they make the referral to the CPS, then CPS offers this voluntary service to the mothers. And in order for the mothers to be eligible, they either need to have custody of the infant, or reunification is a plan. We're interested in maintaining family integrity whenever possible, and so if the child goes into foster care, then that wouldn't be we couldn't work with the mother at that point. And then the mother is referred to our peer workers. And we have 3 half-time peer workers across the state. And I mentioned that there is the referral in Massachusetts. Automatically, every child under the age of 3 that comes into CPS is required to refer. And we do have informed consents between early intervention Part C and Helping Hand, and that has been a little harder for us to open up those channels of communication. And I do want to also say that while we have been doing our work with our CPS agencies across the state, they have been undertaking a significant organizational shift and a new practice model. And so while their offices are all learning how to do things differently in a new and improved way, they've also been making time for us. So that's quite a challenge for them and for us to continue this work in the midst of all this chaos. And so again, I do want to thank the Massachusetts Department of Children and Families for hanging in with us at this time of budget constraints and practice change.
Christina, I'm going to read a question that I'd like you to address as you go on. Someone pointed out that California responds only once a child is born, which I think is consistent with most, if not all, states. And we're actually doing some work right now to see if there are any states that will respond and open a case. The question is, how should we deal with that? Can the state or federal law allow CPS to investigate women likely to have a SIN? So
that's a great question. So quickly to address that, I mean, one of the advantages I think we've had is that at the Kemp Center, which is where I'm located, we have a pediatric lawyer who's also a sociologist. And so he's done a lot of work with us and with a legal work group that we've had through our program to look at some of those issues and what's possible. In Colorado right now, it is not legal for CPS to open a case or do anything mandated with a woman who's pregnant and doing anything but using substances. However, we already knew that, like I said, I think we came into it knowing that 30 might be overstating, but people were already reporting to the Child Abuse and Neglect Hotline women that were pregnant and using. So that's where we decided to kind of try to respond to that. But and I won't go too much into that because we're talking about a couple other things, but it's been very difficult for our specialized team to engage the pregnant women in terms of services. Our lawyer, just in order to kind of understand what the issues are around it, has been kind of looking, that's why I had been asking Amy if any states allow like a dependency and neglect petition to be filed on an unborn child. In Colorado, it's not. What they do is they take the information, they put it into the referral database, and they alert the birthing hospitals. So that they do something with it. So they would call, for example, Denver Health and say, hey, we've gotten a report that so-and-so is doing this, and would you look for her? She might be delivering around at this point. In your packet, you have the Colorado, it doesn't say Colorado on it, it's a community standard for maternal newborn drug screening. And I won't go totally into a lot of the details, and I won't go so much into our development process, although we do have a very strong hospital group, mainly because the PI is from the hospital and a very strong pediatrician in this area. And so it was our work group that came up with this community standard, which we have found what a lot of other people have found, which is that even within hospitals, even if they do have a standard, which a lot of them did not even have one on the books, people don't know what it is. People might not use it. I do want to, well, before I say that, another thing in terms of the referral that's really important, we found that birthing hospitals are the primary referrer and identifier of substance-exposed newborns, but also our probation and parole system is our second highest referral source to the Child Abuse Neglect Hotline. I think they're catching a lot of the pregnant women because of they're having to do drop UAs, but they're also have some policies around reporting women with children. So I just wanted to acknowledge that. So it's not just necessarily, we're not just looking at the birth hospitals. In Colorado, the year before we started this project, they passed a law which says that if a baby is born positive for illegal drugs, or I think it's a Schedule II legal drug not prescribed by a physician, it's an automatic report from medical staff to Child Abuse and Neglect Hotline. Now, so that kind of made it an interesting culture. They did not specify who you test, and they did not allocate any services. And so we're unclear of what the result was, but another thing that we learned through our work groups, which is really important, is there was a Supreme Court case, South Carolina versus Ferguson, which involved hospitals not getting consent for drug testing, and then the information ended up being used for prosecution. So our hospitals legal groups are very much falling back on that as around issues of toxicology testing. So basically, we really advocate for universal screening, which is not necessarily toxicology testing, but is easy to use, and I think we would all say valid and reliable, as much as we can get that going, and to train people to using it. Protocols for verbally screening women. Again, you can see we're advocating for screening for alcohol, illegal and legal drugs used during pregnancy, and also tobacco is a huge prenatal issue. The hard thing about alcohol is our child welfare system will respond to alcohol, reports of children that have been exposed to alcohol, but a mom basically has to be flagrantly drunk or unconscious when she gets into the hospital for there really to be some kind of calibration, I think, from the hospital side that she's using alcohol inappropriately. We had a lot of our hospitals that are more kind of on the edge of suburban come to us and say, we are really seeing prescription medication used inappropriately during pregnancy, and what can you guys tell us about that? And I think we would say, that's why we suggest that it be included into a verbal screen.
We also felt that there should be very clear referral procedures that go along with screening and the brief intervention. So it's not just the screening for the purpose of screening, but with some follow-up. So.
Right. I think there's multiple reasons for screening. Thanks for bringing that up. Even if Child Protective Services doesn't become involved, or if you have a mom that doesn't rise to the level of reporting to Child Welfare Services, there are other reasons to screen for the health and of the mom and for the health of the baby. And so I think one of the hesitations that the hospitals or doctors have about testing or screening is that, okay, what do we do now? And a lot of them don't have the resources to really work with moms and get them engaged into treatment. So that's an important aspect of it. Back to what everybody else said, what you'll see in the Colorado protocol is not an algorithm, but kind of some ideas around testing, and also some ideas around risk factors and when to test in terms of toxicology testing. But one of the things that we feel like is important is not to have an over-reliance on toxicology tests. So I think, there are people that would argue it's always going to be better to have a great verbal screening, if you can do it well, than to rely on toxicology tests. Toxicology tests are going to give you kind of a moment in time for the most part. So you can have, one of our concerns is, okay, well, you know a mom's using, or a mom admits to using, but her toxicology test comes back negative. It doesn't mean that she hasn't been using throughout the pregnancy. And unfortunately, sometimes in terms of treatment response or child welfare response, you can get a response like, well, the test was negative, so we're not going to do anything about it, type of thing. So what we don't want to see is an over-reliance on that. And I think there's a lot of issues in terms of the screening. Some of our preliminary information shows that moms will admit to using marijuana, but they won't admit to using something like cocaine or methamphetamine, which they know in Colorado is much more likely to catch you a child welfare case than marijuana.
At this point, we should probably move on to talk about engagement and plans of safe care. We are going to turn it over to Enid.
I will say, I just forgot something, that in Massachusetts, in our Helping Hand project, we consider prescription drug misuse illegal use. So I just want to clear that up. And even though in Massachusetts now it's a civil offense to have a small amount of marijuana. We're still considering that an illegal drug, and that has caused a lot of confusion, as you might imagine, everywhere we turn. The literature is very clear, however, that regardless of the substance, except for alcohol, the substance exposure that children receive in utero is important to address, and there are clinical interventions obviously that need to be made, but it's the postnatal environment and the children's environment and family as they grow that really can make an important difference in these lives of these substance exposed newborns. And so you'll see that we have all chosen a variety of staff positions to work and to engage with these postpartum women. Now, anyone who works with a postpartum substance-using woman knows that she's typically very hard to engage. And I think that all of us have experience of finding it to be a challenge. And so we all know that flexibility, perseverance, creativity, and being strength-based are really important qualities to use when you're working with substance-exposed mothers, substance-exposed newborns' mothers. And we really emphasize the importance of strength-based approaches, because a woman who uses substances during her pregnancy is probably not used to receiving any positive feedback about her choices. She has obviously made some poor choices, but all of our staff members, I'm sure, in our different projects, try to help her identify what it is she's done well and to build on that. And we have had different strategies and different people to do that, but all of the people that we have worked with in our projects have a firm understanding of what is substance use, what is misuse, what is dependence, what kind of recovery strategies are necessary. Is it 12-step or outpatient or residential treatment? There's a whole menu of options that these specially trained people have been using. And it's really important for replication to remember to be very clear about your linkages. We try to do as many of those warm handoffs as possible, making sure that there's a lot of cross-training between agencies, and so service providers know to whom they should refer and what will happen in that referral process. We try to follow women into treatment, and when they get out of treatment or when they get out of jail or incarceration. And so it does, again, need great flexibility and patience. And I think the most important word that we can use for the mothers of substance-exposed newborns is hope. And we are the bearers of hope for them. And we try to remind ourselves of that when we become frustrated because their cell phones were turned off or they don't always answer our calls.
Liz?
So one of the keys is really having flexible services, I think, in terms of providing services to these families. Obviously, their basic needs need to be met up front, and certainly in our case and everybody else's, I'm sure, treatment is one of the big first pushes for these women, is to try to get them to accept some level of treatment, but then also just basics like housing and transportation and how will they get to and from the different services that they really need. Helping families create family service plans as well as follow through on them, and that may be either in conjunction with child welfare if the family is involved, or if the woman is pregnant and does not yet have a open case, to help them develop a plan for how they're going to take care of their baby, how they're going to stay, enter treatment, but then also look to the future. Developing relationships, agreements, getting women really tied in with their treatment providers, And also, again, the flexibility, where to meet, how long to meet, just really having some sort of flexible, maybe a 10-minute check-in is all they need. So not having something that occurs on a 1 hour, once a week in a certain place, but really meeting folks where they are at. And finding women, too. We've had situations in Eugene, and, someone knows there's a woman and she's using and she's living, in the back of an Albertsons. So going and looking actively for these women and trying to engage them. So that's a very flexible service that is different from how we often provide services. In terms of plans of safe care, Healthy Connections, as Celeste was mentioning, works really closely with Family Drug Court. And so Family Drug Court has been really instrumental in helping actively encourage families to take advantage of that program. So while it's not mandated, it really will look favorably to the Family Drug Court clients if they are participating in those services. C-SIMI, when it has child welfare, primarily works with child welfare involved cases. And so Christina and the MD on the project will be part of those conversations and casework team in order to make a decision about what the safe care plan will be. So again, it broadens, it's not just child welfare employees necessarily, but a much broader perspective from a psychology perspective, what's in the best interest, from a medical perspective, what's going to be a really good safe care plan for this baby. So it again broadens the discussion. A helping hand, Enid will talk about within Project FEAT, again, the SEN team, which has that broadened multidisciplinary team to help make decisions in the hospital, has really helped with different types of community resources that might be available for safe care. And the family advocate is able to accompany that woman from the hospital into treatment or from the hospital into other community services and be able to provide some continuity in that safe care for the child. Again, with Project FEAT, the family advocate, we could choose which community organization was going to receive some funding for a full-time person. For the FEAT project, we chose the Family Relief Nursery, which has such a wide array of potential services for the family. And originally, we thought our family advocate might be able to stay with these families for a period of time, and really that would be ideal if you could hook up with a woman when she's pregnant and stay through the first 2 or 3 years of that. That would really be ideal. But there was such a need during pregnancy to have case coordination and help with recovery support that what our family advocate has ended up doing is kind of working during pregnancy, hospital, maybe for the first few months of the child's life, but then hooking them up within this relief nursery organization. And the relief nursery serves children, can potentially serve families and children who are at risk for up to 5 years. So that provides a nice continuity and warm handoff. It's within that organization. They can just stay there, and they have many, many different services, including home visits, respite, parenting, drug and alcohol recovery and support, EI, ECSE, screening and referrals. So that really works well. And so our families also, they may be monitored through child welfare in terms of safe care. They may be monitored through the treatment provider. There may not be an open case because the treatment provider is so actively involved, or they may be receiving outpatient and family advocate services. So all of those different ways, the baby is being monitored and watched quite closely for the first couple years.
I'll be brief and say that the Safe Care Plan is initiated, of course, by CPS, but we have a case conference where CPS, the caseworker, the supervisor, the mother, and then any collateral members early intervention, family members, partner, if there's a partner in the picture, and the helping hand peer worker all work together to make sure that they've all agreed about what the safe plan is and what the plan of safe care is, and that they're having the same goals and the same strategies, and that's been quite helpful.
I want to just present another question that came up. Somebody wondering what your engagement rates are, both for pregnant women and at the time of delivery. If you all are measuring that.
We're measuring it in terms of, it's been very much a challenge with the pregnant women and having a caseworker from child welfare do the engagement. So we're basically measuring just in terms of whether, if the engagement goes on past like a first visit. And then I think in terms of engagement, we're personally not measuring anything about once there's an open case in the relationship with the child welfare worker.
We actually are measuring engagement at the beginning of the pregnancy and even after the mom delivers. That first meeting is very crucial with these substance using women as far as forming that relationship. So we continue working with them through their pregnancy, even after they deliver. We find that most of the time they're even more in need of our services after the baby is delivered and has been identified as a substance exposed newborns, helping them navigate through the child welfare system, as well as being an advocate. Oftentimes these moms have never had anyone to speak up for them in their behalf. And because we've been able to engage with them at the beginning of their pregnancy or early in their pregnancy, we're able to be there as an advocate to say, yes, this person has been part of our program. Yes, she has been going to treatment. Yes, she has been involved in mental health services. Yes, she's been doing this. Yes, she's actively seeking employment. Yes, she's actively looking for housing and those kind of things that oftentimes they have not had in the past. And also to add to that, with our drug court, they've also added a new portion of that, which they call our family support court, which now they're taking moms that are pregnant and are volunteering to go into this drug court that's special for women who have there's no baby. And our child protective services are also a part of this team. So there is some history being made prior to the delivery of the baby. So we're very, very excited about that.
Celeste, can I ask a question? So the women are choosing to do the family drug court as opposed to just a typical drug court?
Right, it's called Family Support Court, and they actually sign the papers and everything, and it's a voluntary, and it's our project along with the drug court, along with our child protective services, and these women are pregnant, and there actually is no baby yet. So.
And that's all possible because of one of the regional partnership grants, right?
Yes.
Yes. So, what is or can be done to make this important work, move this important work into the preconception or interconception period? And I know there are copies on your table of reports summarizing findings from a series of focus groups that we conducted last year with OBs, pediatricians, and child welfare administrators. And that is an issue that came up particularly among the physicians, and so that is addressed to some extent there. I'm not sure, I know there is some work going on. I don't know that any of you all, are you all doing some work in that?
We aren't doing a lot, but we do work very closely with our Healthy Babies, Healthy Communities Collaborative, and they are very interested in prevention and interconception type of work and getting more information out there. And so it's difficult in our project because there's such huge issues just related to once the woman is pregnant and hospitals and postnatal. So we were focusing on that period with understanding that this preconception piece is so huge as well, but prevention has been working very hard with that, and we collaborate with them very closely and share as many resources as possible.
And as I mentioned earlier, Massachusetts is doing a lot of work in SBIRT, which is prevention, the essence of prevention.
What is the role and process for involving the lay or community and frontline workers in this work?
We work very hard to accommodate their schedules. All our meetings are designed to in their offices and to meet their time frames, and we help let them really set the agenda as far as their work with us. And so we spend a lot of time just accommodating ourselves to their needs and their resources, and giving them a lot of positive feedback. We have, at each of our local implementation meetings, we have a case summary that lists a lot of information about the work that the peer worker is doing with the mother, the profile of the mother, what the current goals are and everything for the mother, what's being done, what isn't being done. And we find that communication is one of the best and most important ways to make a healthy collaboration, so that everybody knows what's going on. There are no secrets or surprises.
One of the things that we do is we are always out in the community saying, we have a free speaker. What are your needs? Yes, we can do that topic. So what we try to do is get out in the community with the frontline staff and all these agencies, and we'll come in and we'll talk about substance-exposed newborns. We'll talk about drug use. We'll talk about HIV. Whatever the needs are, that yes, we can do that. And so that's how we are able to get into a lot of these community agencies and talk to their frontline staff or their lay people, just by getting on their agendas and talking about different topics, conferences, whatever there may be within the community. We're usually there.
So to be honest with our time and get you all out of here on time, I want to just make a few concluding remarks and some logistical information. Just to recap some of the key themes that have come up over the last 4 years with these projects: the importance of developing trusting relationships on different levels, as we just discussed, not just at the administrative level; jointly developed procedures, as well as a plan for consistent implementation of them. Policies and procedures don't have any impact if they aren't implemented and implemented consistently. Screening early and often. I think there's universal consensus here that screening is critical and has to happen throughout the pregnancy. And there is some controversy about the use of testing, and I think that that's an issue that will continue to be explored as these projects and the whole field moves forward. Identify both alcohol and legal drug use. Although the CAPTA law only requires illegal use, I think there's clear consensus that alcohol is a critical issue that needs to be addressed as well, and also prescription drug use. That there should be a single contact person with specialized skills and training. The exact skills and qualifications of that person seem to be less important than the fact that there is somebody that is the single point of contact and has the skills and resources to establish a relationship with the families. And that there be coordinated and comprehensive services available to the families, to the infants as well as the families. And by family, we really do mean the whole family. We talk mostly about the moms here, but we are including the fathers, the siblings, whoever the family identifies as family in that particular case. So thank you all very much. Thank you to these fabulous presenters who I very much enjoy working with, and we invite you to continue to talk with them and ask them any additional questions during the lunch following. Thank you.